All right. Well, thank you for the opportunity to present for you guys here today. I have no disclosures. So as we know, peripheral arterial disease exists in a spectrum. We can have claudicants, rest pain, and as we increase in the severity, wounds can grow in extreme complex, like in this case, as you can see here. To add complexity to the problem, we know that diabetes and renal failure are on the rise, and this increases the complexity because this disease process affects the distal tibial arteries and make revascularization even more complex, especially when they affect the pedal arteries. An even more extreme group to add to this is what we are now calling no-option CLTI. And how do we define this group of patients or population? So for us, these patients have high frailty, they have a high MAX score, a high Wi-Fi stage, and if you're familiar with that classification, high Wi-Fi stage, when they're in clinical stage 4, they're at high risk of an amputation. So we try to at least attempt revascularization. And then, of course, these patients have limited autologous conduit, i.e. they don't have adequate vein for a distal tibial target bypass. So putting all this together, what no option CLTI, but these patients have limited revascularization options. They have high adverse limb events. They have poor survival and poor limb salvage rate. So to that end, I want to bring to you venous arterialization. So originally described in 1974, the adaptability of this venous arterialization has been plagued by small cohort studies and lack of standardization, so the adoption has been quite poor. So for today, I want to describe to you the surgical technique, the endovascular approaches that we have developed, and review some of the current data that we have, some coming from our group. So what two techniques do we have? We have the superficial venous arterialization and we have a deep venous arterialization. So for the superficial venous arterialization, which is going to be to your left, the blood flow is redirected through the greater saphenous vein to the foot, and then it returns to the deep system. And then for the deep venous arterialization, as you can imagine, the blood flow comes through the deep system, i.e. through the posterior tibial vein or sometimes the perineal vein, and then it returns to the saphenous vein. So how do we decide who gets what? So obviously we want to start off with the complex patient, complex wound, advanced CLTI, really no good options for a native revascularization or for good bypass target. So for superficial venous arterialization, we have to take into account, as I will demonstrate to you here shortly, that to create a deep venous arterialization, you have to have a donor artery. And with that donor artery, flow to that is going to be canceled out. So for a superficial venous arterialization, patients that usually have an occluded anterior circulation to the dorsum of the foot, we pursue this, i.e. they have flow through the posterior segment, and we want to improve that. So how do we construct these? We kind of do this kind of like as an in-situ bypass technique. So it's a single incision at the below popliteal area, and we transpose the saphenous vein onto the popliteal artery. Then we get percutaneous approach, as you can see here in these images, and through a 5 French sheath via the medial marginal vein, we insert our percutaneous valvulotome and perform valve lysis. After that has been completed, usually there's some large branches that are going to be stealing flow. We try to identify those on ultrasound and ligate them. And then we bring the patient back for angiography for any additional coiling that may be needed, because we have to control the flow on these fistulas that we're creating so they're not stealing flow from the native system. And that is some judgment calls that we see that on angiography. So this is what it looks like, a superficial venous arterialization, as I mentioned. And here's a video. Let's see if this plays. As to what it looks live. And I want to bring your attention to, don't get to this distal feeling here, because that is the important feeling that we want to see after we create this, because those small valves that are grow incompetent is what's going to actually provide flow distally and begin to provide perfusion. So now for the deep venous arterialization, as I alluded to earlier, these patients are going to have a donor artery, meaning that donor artery is going to be stented and it's no longer going to be in the circuit. So for these patients, we usually try to do patients that have a native anterior circulation and an absent posterior circulation, and again, complex wounds. And the way we create this procedure is kind of what we had our talk earlier about difficult or complex access. So we bring in an antegrade common femoral or SFA access arterial. Then through the venous side, we stick the lateral plantar vein. We bring those wires, one through the venous side, one through the arterial side. We establish crossing, usually with an outback catheter from the arterial side to the venous side. We establish a through and through access. We perform the valve lysis with a series of balloon angioplasties. Then we stent across that segment, essentially creating a fistula from the arterial segment to the venous segment via that covered stent. And this is what those images look like for a deep venous arterialization. But that's only one side of the story. There's the other side of the story, which is equally as important besides just having a successful outcome. We could just say, yeah, we have a great angiogram, we're all done. But quite frankly, a lot of it comes to this second part, and that's wound care and podiatry. So we have two main drivers for early foot surgery, and that's infection or severe pain. But we do try to delay minor amputations or TMA or guillotine TMA on 4 to 6 weeks. And we try to do that because that allows the maturation of the venous arterialization. I cannot stress enough that this requires multidisciplinary care, and it requires motivated patients because, as I will show you in the data, these wounds take about 6 months to 12 months to heal. So a patient that doesn't have adequate support, they're not motivated, are not great candidates. So a patient selection is very important for this procedure. So this is a paper that we published here recently, and this was a dual institution prospective study from 2017 to 2020, and we included any CLTI patients, as I mentioned, with clinical stage 3 or 4, high MAC score, not suitable for any native revascularization. We excluded any acute limb ischemia and any patients with high mortality or guarded prognosis, and of course we looked at major amputations, mortality, and wound healing rates. Due to a lack of time, I'll just present some of the data. But as you can see here, freedom from amputation was close to 80% in the total group, and we didn't demonstrate any difference on the outcome between open or endovascular procedure. I should note that this was a small sample size, 41 patients, but the largest to date. And then when we look at patency rates, primary patency really poor, 28% amongst both groups. But it is important, and I stress that because these patients need high reintervention rates to keep these open. But when you look at secondary patency, it's 70% amongst both groups. And similarly, recently published as well was a PROMISE 2 study. This was a prospective study from 2019 to 2022 regarding the lymph flow device, which I will introduce here shortly. But the inclusion criteria was any CLTI patient, again, with no option, absent pedal targets or absent conduit. They excluded any systemic infection or advanced heart failure, worsening wounds, and they looked at the safety and efficacy of the device, of course, amputation-free survival, and mortality. So lymph flow device is a little bit different to what I explained differently, and it has three main differences that I want to point out. Number one is that it has guiding catheters that facilitate the crossing from the arterial to venous crossing because it guides you on where the crossing should be done. Secondly, it has an antegrade valvulotome that facilitates valve lysis. And third, they have tapered stents, which are really nice when you're going from a 3 millimeter vessel to like a 5 millimeter vein. And similar to our study, their amputation-free survival was around 66% for the entire cohort of 105 patients. And their survivability during the 12 months was 88%. Their patency was poor for primary patency, 26%, but their secondary patency approached 68%, similar to our study. So again, re-stressing that need for re-interventions during these procedures and close follow-up. So to conclude, peripheral arterial disease has progressed to involve more distal distribution and complex calcium patterns. Venous arterialization techniques have evolved and require a patient-centered approach, similar to what we have heard here earlier about having aortic centers. I think advanced limb salvage requires the same, so you can have a multidisciplinary team and the adequate procedures and follow-up for these patients. We have to consider the anatomy, the motivation of the patient, and the family support. And that when we consider arterialization, we have to consider that anatomy to be able to offer the best for that patient. Some future directions, I think the use of ultrasound, both with pedal acceleration time, reducing radiation, is something we can look into. Of course, larger sample size, rather small sample sizes thus far, and to validate a lot of this data, we need larger sample sizes. And we need to start talking about predictors of success. Which patients are going to have successful patency, which ones are going to require more re-interventions, and which are going to be likely to fail. These are all things to come. So thank you for your time.